Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Charles Hawley, NAUTO's Director of Projects.
Thank you, Mara, and thank you everyone for joining us for this panel discussion on state investments in primary care, the current state and future options. I want to take just a quick moment and thank our session sponsor, California Healthcare Foundation. And also I will introduce Jenn Toms with Onpoint Health Data, who will be moderating today's session. Jenn, you have the floor.
All right, thank you, Charles. I'd like to welcome everyone to our panel discussion today, and good afternoon from here in Maine. I'm Jenn Toms, Onpoint's Manager of Business Development, and as Charles mentioned, I'll be moderating the session today. Our session is titled State Investments in Primary Care, Current State and Future Options. A little bit about today's agenda. We're going to kick off with some brief introductions from each of our four panelists, and then we'll dig into a discussion around what we've identified as 3 key questions as they pertain to state investments in primary care. And then we'll conclude by using our remaining time to address any questions and open forum time from attendees. So our 4 panelists today bring a collective wealth of knowledge and experience, and I am honored to introduce you to Rachel Block from the Milbank Memorial Fund, Richard Slusky from the New England States Consortium Systems, NESCO, Karl Fenison from Onpoint Health Data, and Dolores Inagihara from the Integrated Healthcare Association, or IHA. So with that, I'm going to turn things over to our panelists so they can provide some background information on themselves and their interest in primary care investments. So Rachel, please kick us off.
Thank you very much. I think at this point, we need to go to the first slide. Or not. Do we still have Charles? Okay, here we go. Thank you, Charles. The next one, please. So hello, everybody. I'm Rachel Block. I'm a program officer with the Milbank Memorial Fund. And one of the areas that I have been focused on for the last several years is our work with states to measure and to take actions around primary care spending. The map that you see here represents what is currently going on across the country. And there's a few things that I would like to say briefly about this. First is you can see that there are a number of states that have taken actions to measure primary care spending. But if we did this in an animated form and we did it over a time series, what you would find is that this has been a very organic, and that different states have been adopting these measurement activities at different times. The second, as you can see from the right hand, is that some of them have done this through legislation, but some of them have done it through regulations, and some have done this through executive orders. So there's a variety of different pathways that states have taken to set their strategy for measuring primary care spending. And I think we all know that if you've seen one state do something, you've seen one state do something. And so the story that we are here to share with you today is our collective and individual efforts to try to bring some more consistency to the way in which these primary care spending measures are done. And this doesn't happen by itself, and it doesn't happen overnight. So our partners at NESCO and Onpoint and the Integrated Healthcare Association will be sharing detailed information about their efforts to come up with consistent measures and standards. So with that, I think I'm turning it over to Karl.
I think it's actually to me, Rachel.
Oh,
So,
sorry about that, to Richard.
okay. That's all right. Hi, I'm Richard Slusky. Just a little background. I was CEO at Mount Slusky Hospital and Health Center in Windsor, Vermont for 28 years, from 1982 to 2010, when I retired from the hospital. In thinking about that, I realized that I'm probably began my career before many of you were born who are watching this. So I don't know if that's a lesson for me or you, but there's hope for all of you. I retired in 2010, and immediately upon retirement, I was asked by the state of Vermont to become Director of Payment Reform, working with the Green Mountain Care Board, which is the healthcare regulatory body in Vermont. I was part of the team that worked on Vermont's all-payer model agreement with CMS, CMI, and CMMI. And so we developed the framework for the all-payer model over about a 4.5, 5-year period. And I retired from that position in 2016, and then began to do some consulting work. And in 2017, I was approached by Elena Nicolella, director of NESCO, to facilitate a primary care work group that had just been formed through the NESCO organization. That's the New England States Consortium Systems Organization. And the work group consisted of representatives from the 6 New England states. That would be Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And the charge to the group, to the work group, was to look at each state's primary care payments, what were their state health policy environments, and what were their state data capabilities. So we began our discussions in 2017, really looking for something for us to achieve, and what could we do that might together that might actually make a significant difference. And in November 2018, the Primary Care Collaborative actually published its consensus recommendations, one of which was that primary care investments should be tracked and reported through, I don't actually need that slide, so if you could take that one down, through standardized measures at the health plan level across all payers. And although several states and others had conducted studies of primary care investments, there was no national agreement on who primary care providers were or what are actually primary care services. So what should be included in the study. We thought that was an interesting topic. And so beginning in early 2019, we began as a work group to discuss the possibility of our 6 states actually agreeing on definitions of primary care providers and services. And with the ultimate goal of producing a report on primary care investments, payments, through using the APCDs in each of the states to collect the data and use it to report the information. The purpose would be to measure primary care payments as a percentage of total healthcare expenditures, to provide a framework for a comparative analysis of these primary care investments in each state, and to identify needed improvements in the APCDs regarding the collection and reporting of that data. So it took the work group over a year of internal discussions to actually come to agreement on these definitions. This is not an easy task, as I'm sure many of you have discovered. And in June 2020, the NESCO Board of Directors agreed to finance the work group's proposal and engaged Onpoint Health Data to provide the analytic services for the report. The report was completed at the end of 2020 and released in January 2021, and is available on the NESCO website. To our knowledge, this is the first multi-state report on primary care investments using standard definitions of primary care providers and services. And so we'll discuss more of this, more details about this report during the panel discussion. But I just wanted to introduce the process that we undertook to actually produce it. Thank you. And I'll turn it over to Karl. Karl?
Hi, I'm Karl Fenison, Director of Analytic Development at Onpoint Health Data. I've been working to generate analysis and reporting on primary care since the late 1980s. And I've sat on a number of stakeholder groups related to primary care spending and generating reports in different states. So I was happy to work on this, the NESCO project across all 6 New England states. Charles, can we have the next slide? So one of the processes that we did was to come up with definitions of both the numerator, primary care spending, and also the denominator, total healthcare spending during this project. So we worked from prior studies and reviewed again with the NESCO group definitions of primary care providers and primary care services. I wanted to stress that this was an all-payer model. So we needed codes that not only applied to commercial, but also to Medicare and Medicaid data. So we ended up with these definitions of primary care, and these are actually ranked in order of highest cost in the results. So internal medicine was the highest in terms of total cost in the report, followed by family medicine across the states. We had 29 different taxonomy codes. You need taxonomy codes in order to be able to operationalize provider taxonomy codes in the claims data. And these are the rank order. One interesting note there is that we found that the 3 more urban southern New England states, internal medicine was the leading provider type, whereas in the 3 northern New England states, which are rural, family medicine led the way. So that was one thing, was the taxonomy codes. Then we defined the primary care services. And again, these are ranked in order of the actual results, where most of the spending in primary care was with office visits, followed by preventive visit CPT codes. We spent a lot of time with the HCPCS codes that are also used by Medicare and Medicaid. States made recommendations. For example, there was a back to school visit code that one state recommended that doesn't exist in any other previous study that I'm aware of. So there was new learning from this. All the codes that were used are in appendices, as well as the full specification in the actual report that can be found at the NESCO site. I wanted to emphasize that this was a distributed model. The data, unit record data, did not leave the states. We created specifications. They were reviewed by all the states and modified. And then the states created summary level data. We had 7 different reports stratified by payer, by age and gender and other factors. The typical reporting in an Excel file had about 20 different columns. So we broke out things like dental and vision and capitated fee-for-service equivalencies and our various different narrow and broad definitions. We also incorporated member month counts for medical and pharmacy, so we could calculate per member per month rates as part of our quality assurance process. So I just wanted to emphasize the denominator. We also, in addition to separating things like dental and vision out and fee-for-service equivalencies, we also broke out, obviously, pharmacy, and then we broke out for Medicaid social support services, things like transportation, case management, home and community-based care was separated out so we could remove that because those are non-medical services. So there was a lot of detail provided back from the states in summary fashion by various different stratifications. That was essentially our methodology. And I'll go on to the next slide, please. So these are our results. And overall, for all payers, combining all payer types across the 6 states, we had a rate with our most narrow definition, which is primary care practitioners, with selected some 124 different CPT HCPCS codes, primary care services. Overall, with that definition, overall payers combined, we got a rate of 5.5% of total healthcare expenditures. Moving to a broader definition, we got a rate of 8.2% across all payers. And as you can see, the percentage is lower for Medicare, Medicare Advantage, and then higher for commercial and highest for Medicaid. And this follows some other previous studies that have been done in terms of that ranking. I should mention that these are a percent, so it's based on total healthcare expenditures. Obviously, Medicare patients incur much more cost than commercial patients, so we might expect the percent to be lower. We also include in the report per member per month rates, and when you use that statistic, then Medicare becomes the highest on per member per month, and Medicaid is actually the lowest. Other things I just wanted to mention real quickly. Again, the results are in a 70-page report. All the specifications are documented. There are many more graphics and tables with more detail. We also included information comparing to other previous studies, for example, Milbank and the Baylor study or the Oregon study and other studies that have been done, RAND study, and so on. We found the range, the results here fell within the range of these other studies. There is some significant range between some of the states, but that's also been shown by payer in those other previous published studies. There can be quite a range of variation within a payer type and between states. So with that, I think I will turn things over to Dolores to talk a little further about this.
Thanks, Karl, and good afternoon, everyone. I'm Dolores Inagihara with the Integrated Healthcare Association in California. I've been with IHA 16 years, leading various collaborative measurements, reporting, transparency, and analytic initiatives. IHA has a voluntary multi-payer claims database with about 20 million commercial and Medicare members in California. And we've used the multi-payer claims database to conduct multiple iterations of primary care spending calculations and analysis in partnership with Covered California, the state's health benefit exchange, and Onpoint Health Data and RAND, to support the policy question of setting primary care spending floor or target for the qualified health plans of Covered California. More recently, we've expanded the partnership to also include California Healthcare Foundation, Milbank, and Baylor Health. We started with the commercial population since that was most relevant to Covered California. We did calculations in categories so that we could report out results in different ways, including both the broad and the narrow definitions that Karl just spoke about. We are actually really fortunate to be doing our initial primary care spending work with Onpoint, who had experience with measuring primary care spending in other states. And our work was occurring at the same time as the NESCO work. So we were actually able to align our PCP definition and code lists with NESCO. So that was really exciting from one coast to the other coast to be working together and really aligning our definitions. And I just want to emphasize the importance of having code sets and how important that was in being able to generate results that are apples to apples kinds of comparisons. Something a little more unique to California, with the amount of capitation in California, we had to figure out how to assign pricing to specific services under capitation. And we did that in different ways. And we're also just starting to use the Baylor Health tool, which we'll talk about a little bit later in more detail, to collect more information on non-claims payments. I think two unique things to keep in mind that we've been able to contribute. One is the level of measurement. Most of the studies have focused on payer types and product types and plans. We were actually able to take it down a level to measure provider organizations in California. And also, in addition to measuring primary care spending using actual pricing, we also applied standardized pricing to try to remove the impact of negotiated pricing. And so those are some things I think that are unique in what IHA was able to do with primary care spending. And with that, I'll hand it back to Jenn.
Thank you, Dolores. So I think you brought up a good point that's going to lead me into our first big discussion topic for today. Seems like an easy question, but I think everyone on this panel and probably a lot of people attending know that it's not. In your opinions, what really is the definition of primary care? How does that vary?
So I'll take a crack at that one, Jen, if I could. And if you could put up the slide 3, that would be helpful here, I believe. Right. Thank you. So when we started talking about the definition of primary care, and I think this has been a difficult discussion in many of the states. Who should be included in the taxonomy, and also what are the services that should be included if we're going to measure primary care in some way that can be compared from state to state. So if states are thinking about establishing targets for primary care payments, and they want to know where they stand relative to other states, I think it would be important to understand what exactly is included in those definitions of primary care providers and services. And I know there's been a lot of discussion and some controversy about who should or should not be included as primary care providers. So this is the list that we came up with in our defined primary care providers. And I should note that, as Karl said, there are in that taxonomy, in internal medicine, for example, there's also internal medicine for adolescents, adults, geriatrics, hospice, palliative care, etc. So there are subcategories in each of these practice specialties that we included. We also included federally qualified health centers, rural health clinics, primary care clinics, and critical access hospitals as part of the taxonomy, but with very restricted services that they offer relative to primary care. So that was our definition. Now, there was a lot of discussion whether OBGYN should be included or not, and whether naturopaths or mental health providers should be included. And what I have argued, and I think the group agreed ultimately, was that it would be good to have a core definition that we could all agree upon. And then if states have either legislative requirements or other requirements that they would like to include in their definitions, they can do that as an addendum to the core. So, for example, we would have our report. We did include actually definitions 3 and 4, which included OBGYN specialists and primary care providers offering OBGYN services. So we did take that into consideration, and we were able to identify the impact that had on the percent of payments relative to total healthcare expenditures. So if states wanted to include naturopaths or mental health providers, et cetera, they could do so as an addendum for their own state purposes. But when they were using it as a comparative report, we would recommend they use the core definitions. And we did the same thing with primary care services. And one example I could give you is for immunizations, for example, we used the administration fees relative to the immunization. We did not include the cost of the vaccines themselves. So that's something that states sometimes do. And as Karl said, in the denominator, we did not include pharmacy for a variety of reasons. So I just think our intent here, just to summarize, was to create a core definition that could be used nationwide potentially for comparison of state to state investments in primary care services as a percent of total healthcare expenditures, and then if the states want to add other services, they can do so through their own state addendums. So I'll leave it at that. And that would be my definition of primary care.
Thanks, Richard. I'm going to jump in for a second. I saw we had a question that I think might call on Rachel to see if you can maybe lend some background to as well. So thanks, Mary Jo, for your comment. But it's around the competing needs of standardization versus state autonomy and preference, and wondering what your thoughts are on how legislation might impact legislation or any other state issues might be relating to the definitions of primary care and how that's really impacted.
Well, I think in general, our principle is that the measurement should be fit to purpose. And as part of my map, somewhat simplistically displayed, there is a variety of purposes, or there are a variety of purposes that the states are using these measures for. So if the desire is to more globally assess what is going on in terms of primary care and the significance of primary care to the overall health system of a state, then you might select a broader definition of primary care, because you're really trying to get at what is primary care in the context of overall healthcare delivery and system performance. But as Dolores said, maybe what the state wants to do is set a target for primary care spending, and that target has some relationship to activities around payment reform that are occurring in that state. Now you're getting to the need for a somewhat more specific definition of what will be included in that target, and ultimately how the experience of different payers and different providers will be evaluated using that target definition. So now we're going from a more informational and interesting research question to something that might have consequences in terms of either overall penalties or specific evaluation of payers of how they're paying primary care based on that definition used in the target. So those are just a couple of examples, and they're both legitimate. It really depends on what the state's purpose is.
Thank you, Rachel. Before I move us on to our next question that I want to pose to the panel, just wanted to ask if anyone had any final comments just around the definitions topic.
Yeah, I'd actually like to chime in here, Jen. I think I really like Richard's suggestion of having a core that everyone can agree on, and then having states having the flexibility, or organizations within a state having the flexibility to be able to adapt and build on that for their use case. And so I think that's a really good thing, that we can at least all agree on a core. And I did want to just share, if we could bring up slide number 5, just share a little bit. We also, took in the data in a way that we could kind of mix and match and look at different categories and see what impact. And I thought it might be interesting to just share the impact that different options had. So we started kind of with this restricted taxonomy, provider specialty codes, and restricted procedure codes, and medical costs only in the denominator as a starting point. And we had about 6% in California for the commercial population. The thing that had the biggest difference in terms of percent primary care spending was removing the procedure restrictions. When we removed the procedure restrictions and kind of moved to a broader definition of primary care, that actually increased primary care spending by 4 percentage points on average, which is a little bit more than was seen in the New England states. And then the other things really didn't have as much impact. So when we added in the OBGYNs and the OBGYN services, it really had less than a 1 percentage point increase in primary care spending. And when we added pharmacy into the denominator, that reduced the percent by about 1%. So ultimately, where IHA landed in terms of measuring primary care spending in California was using the broad definition that NESCO used, which kind of had the specific provider taxonomies with without procedure restrictions. But then the one change we did make is we did include pharmacy costs in the denominator, because IHA had been measuring total cost of care for about a decade, including both medical and pharmacy costs. We get the pharmacy costs from the plans as part of our MPCD data. And so we just thought it doesn't really make sense to change the definition of total cost for this purpose. And so we continue to use the same definition we've been using for total cost of care, which includes pharmacy. So that was the one difference. We actually measured it both ways, so we have results both ways, but for our analyses, we've been using the total cost of care definition that includes pharmacy. So just thought those numbers might be interesting for people to see.
Yeah, thanks, Dolores. And I think that leads us really well into the next question I wanted to ask the panel, which is just, in your opinions, what are the benefits or drawbacks or both of using APCD or MPCD data for this type of work?
Well, I can jump in and just share a few thoughts initially. So I think, there are really both benefits and limitations to using APCD data for primary care spending. On the plus side, APCDs have all payer types and in a standard format, the services provided, the payments for those services, which types of providers rendered the service, those are all generally available in a standard way. And so you're able to then use APCDs to produce results in a standard way across the whole population, which is great. The reason Covered California came to IHA to do the primary care spending work is because we have data for almost all of the fully insured commercial population in California. So it could provide context for them to understand the performance they were seeing in their subset of the population. So kind of having that broader context. On the limitation side, APCD information works better in a fee-for-service environment, and not so well where there are more alternative payment models and payments that are not directly tied to providing services. And with the move, toward more value-based payments and alternative payment models, I think this is becoming a bigger issue. So I think Richard has some information to share about non-claims payments in the NESCO study.
Thanks, Dolores. So if we could see that the slide, the bar slide with the non-claims payments, I believe it's 4. Yeah. So when we were looking, we were trying to identify the non-claims payments in our study. And what we found, as you can see, only 4 of the 6 New England states were able to collect and report non-claims payment information. So it was clear that in the APCDs themselves, they did not have that much of that information available. And you can see, for example, in Connecticut, what they were able to report was about 3.5% of total payments were in the green area, the non-claims payments, and 96.5% were claims-based payments. Now, Massachusetts had about 30%, Rhode Island, which has really been focusing on non-claims payments and actually establishing targets for primary care payments for a number of years, had about 23%, and Vermont about 9.3%, 9%. So the issue I think this raises is that if we are going to be expanding non-claims payments, if we're anticipating that these payments are going to be increasing and that the value-based payments are intended to support improved quality, reduce unnecessary utilization, increase focus on population health, then we need to be able to collect more information. I mean, what the APCDs will in the future potentially include will be a smaller and smaller percent of the total payments that are going to primary care. So if more of these payments are actually going to be in the form of capitation or other forms of value-based payments, how are we going to collect that information? Who are we collecting it from? And how do we know where it's going? And Michael Bailett and Milbank recently collaborated on a report that kind of provides a template for how states might think about collecting that information and actually reporting it. But I think this is going to require a good deal of thought among the states about whether they want to approach this voluntarily with payers and the providers, because all of these payments don't go directly to primary care. They go often to systems that then redistribute the money. So I think this is going to be a complex issue that states are going to should be grappling with or thinking about. And whether that's through voluntary means or legislation or rules and regulations, I think is going to have to be thought about. So I'll turn that back. And I know Dolores, I think, got some work on this.
Yeah, thanks, Richard. And so I think, the good news is that Milbank provided funding to Baylor Health to convene a national group and come up with a standard way to try to collect this non-claims payment information. And so I wanted to just take a minute to quickly walk through the 6 different categories of non-claims payment that the Baylor group came up with. You'll see those on the screen here. So the first one is really capitation, case rates, episode-based payments to provide patient care. So that kind of category of kind of lump payments, prospective payments for a specific population. The second category is really incentive payments for primary care performance. And so what are the performance-based kinds of incentives that are being paid, either risk-based or not risk-based? And then the third category is payments to providers in the form of salary, right? So if you have a staff model and salaries are being paid to primary care providers, that's a third category. Moving on to the next slide. The fourth category is a large one and something that we've grappled with a lot in California. So there's all kinds of investments in non-billable services to support population health management and support practice infrastructure that's needed to do population health management. And so things like care management and care coordination, all kinds of data analytics in terms of understanding risk stratification or care gap reporting, those kinds of things. I mean, even payments to support the infrastructure, the health information technology itself. There's also things like, medication reconciliation and use of pharmacists for supporting that kind of work. And integrating primary care and behavioral health and payments to support that. So a lot of different kinds of payments that are not things that you're going to see in a claim, but are really important in terms of supporting primary care. The last 2 categories, one is recoveries. And so that is different kinds of adjustments or recoupments or things that needed to be, paid back. And then just a kind of a catch-all other payment category to make sure if there's other things that haven't been captured in the other categories that they could be reported. And so one of the keys to using this template, and if you could go to the next slide, please, is really being able to know how much of each of these categories to allocate to primary care. Some of them, sometimes it's straightforward. If it's an entity that is all primary care, that's all they do, that's straightforward. Or if it's an entity that doesn't do any primary care, that's straightforward. But what about multi-specialty groups or health systems that do the whole gamut? That gets less straightforward, more complex. And the Baylor tool does have some kind of default percentages to apply, but those are adjustable and can really be adjusted to fit the situation. IHA is in the thick of this, actually, because we are working with the provider organizations that are either multi-specialty provider organizations or provider organizations that are responsible for contracting for specialty services. And so we are actually starting to use the the Bailet tool. We got some funding from CHCF and Milbank to do this work, and we're partnering with Bailet Health to survey our provider organizations and understand the non-claims payments coming into them from health plans, and then how they are actually allocating non-claims payment dollars or other dollars to support primary care, to really be able to support all of the different services. So it's a big undertaking. We're really excited to be doing it. And, we already have claims or capitation information. We collect that in a separate file. So we know what the total capitation payment is. We know all the services that are billable that were provided under capitation, but we don't know all of the non-billable activities that the capitation supports or other non-claims payments. And so we're really excited to be surveying our almost 200 provider organizations to really understand that space more, what's flowing in and how that then supports the work that the provider organizations are supporting.
Nice. Thanks, Dolores.
I don't know if anyone else had any other comments on the non-claims payment.
Yeah, wondering if any of you have, before we move on to our final question of the day, kind of related to this is, what are your thoughts on if there's any benefits to having standardized data collection regulations around this? I'm going to loop in part of Wade's question here from the chat as well. Would you see an improvement if we collected rendering provider ID in the APCD data more regularly?
I guess, yeah, obviously, this is Karl at Onpoint. That would be a great improvement. There's a number of other issues related to that, and I've sat in several different stakeholder meetings trying to work through the definition of primary care, and frequently a physician or someone says, well, if the setting is primary care, then include it. And APCD data, claims data, does not have a setting of care called primary care. Hence the importance of getting some type of a standardized list of taxonomy codes and procedure codes that can be used for a standardized core definition, which is, I think, what we did achieve in this project. One other issue I just wanted to raise on the non-claims data is that, and we haven't really talked about this, in regards to pharmacy, we did collect pharmacy data. All the states provided pharmacy data into our reporting templates. And in the end, it was not used. There were issues raised around rebates and some other issues related to pharmacy that caused us not to use those on the NESCO project. So in terms of non-claims data, and I think a few states are starting to do this, is to collect information on rebates for pharmacy.
Thank you, Karl. All right, I'm going to move us on to our last question of the day for the panel. So question 3 for today is really, why should we increase investments in primary care? What is the evidence supporting increased primary care investment and its relationship to things like increased quality outcomes or decreased utilization and cost? And Rachel, maybe you could kick us off.
Sure. So in part, we are relying on organizations like Integrated Healthcare Association to help us answer this question. They have the direct relationship with the payers and providers who've made the commitment to certain kinds of payment innovations or performance incentives. And so really that relationship of the payers and the providers with Integrated Healthcare Association playing an aggregating and facilitating role in helping to establish how to measure these things is a key design issue here. Having said that, that's on a more granular level. On the national level, there are a couple of other ways to think about establishing the value of primary care investment increasing. The Primary Care Collaborative has been focused on this now for several years. And Charles, if you could go to, I guess it'll be the second to last slide. I think that Dolores was going to talk about that one. If you go to the next one. Thank you. We have a number of organizations. Sorry, I was going to the 2020 healthcare system performance. Thank you. The Primary Care Collaborative has published several evidence reports that have demonstrated specific advantages to increased primary care investment. And they published a national report based on using not APCD data, but data from the Medical Expenditure Panel Survey, which is one of the few national data resources we currently have in order to report on these things on a national level. So if we're trying to establish this, you're not going to do this on a practice-by-practice basis or on a state-by-state basis only. If we're trying to establish the value of primary care investment, we need to look at a larger lens, a larger population. And so these national studies become even more important to advance that work. What you see here is the Commonwealth Fund's 2020 Health System Performance Report. And that, for the first time, included primary care spending measures for Medicare and for commercial. What it did not include was a primary care spending measure for Medicaid, because the national data sets for Medicaid were just recently becoming available. Commonwealth and Milbank are currently co-funding the first national study of Medicaid spending. So we will have national data that will be based on some common definitions, but they are going to be using different data sources. So not perfect to answer some of these questions, but certainly in advance. If you go to the next slide, one other way to answer the question of what is the value of increased primary care investment is to really kind of take a step back from some of these technical questions of how to measure and really focus on what is our goal here and how does primary care fit into the larger healthcare system performance. And so I just want to call your attention to the recent National Academy of Sciences, Engineering, and Medicine report that was published a few months ago based on the work of a distinguished committee of primary care health services research experts, and essentially tried to restate what they thought the overall value of primary care is in terms of improving quality, in terms of improving access, in terms of reducing cost, and also, as we know, an increasing focus on reducing disparities in various healthcare measures. And the conclusion of this committee, with lots of evidence to support it, is that a stronger primary care foundation is really the key to accomplishing all of those things. And while increasing primary care spending alone is not the only answer to how to accomplish that, we aren't going to get there by not focusing on how well we are investing in primary care. So if you go to the next slide, please. One of the recommendations so these are the 5 domains that were included in that report. And so if we're looking at what does it take to accomplish high quality primary care, we need to look at all 5 of these. And in the middle slice, what you'll see, the 5th dimension is accountability. And that is, again, where some of these measurement and research efforts are going. And Charles, if you go to the next slide. So what they recommended at the end of the report was to set up a United States scorecard, or what we're calling a report card, on the health of primary care, and to try to use measures that are already in use, not create new ones, a small number that could be easily understood and consistently defined, build on data that is regularly collected and publicly available, and appropriate for use at the national and state levels. And these measures will include primary care spending, but go beyond, and to address the other qualitative domains of the definition of primary care that was articulated by that committee. And so the next focus of the Milbank Memorial Fund, in addition to co-funding the work that Dolores mentioned, is to work with national partners to begin the development and publication of this United States scorecard on the health of primary care. I can't remember if there's one more slide. Or just to say thank you. So what I tried to capture there is the movement to both more national measurement of these issues, but also to put primary care spending measures in a broader context of how we're thinking about the health of primary care.
Thank you, Rachel. So we've got 10 minutes left in our time, so I thought we could circle back to a couple of the audience questions. I'm going to start with a question from David. Charles, not sure if you can pull it up or not, but I will read it, which was, does the NESCO research provide a target % of total spend that should be tied to primary care based on these standardized definitions? If not, is there a goal to provide that recommendation in the future? So Richard or Karl, could you kick us off with answering that?
Karl, do you want to take it, or do you want me to?
It seems like it's more of a policy question.
Yeah.
So I'll let you take it.
Yeah. So the NESCO work group, the primary care work group, is continuing to meet, and one of the issues that I think we'll be addressing in the future is this issue of how to capture the non-claims payment data. But the other question is related to targets, and several of the New England states are currently working on establishing those targets. Now, Rhode Island has had primary care targets in place for probably, I don't know, it's almost 10 years, I guess now, or at least 7 or 8. And I believe that Vermont and Connecticut are beginning to address the possibility of establishing those targets as well. So the answer to the question is, we did not propose targets in the report itself, but the group is addressing the means of establishing targets in their states in the future, and some already have.
And if I could just add to that, several of the states that Richard mentioned are now looking at these primary care spending levels in conjunction with measuring their overall healthcare spending in their states. And so one of the reasons that the target becomes an important question is to look at it in that overall context of looking at healthcare spending trends. And what we can see in general is that the slice of the pie that's going to primary care has been shrinking, and the other slices of the pie have been growing. So if you accept the notion that improving that primary care foundation is critical to meeting our population and personal healthcare goals, it does seem that setting a target of primary care spending relative to other categories of spending is an important policy tool to help get there.
And just to add to that also, Rachel, I mean, one of the concerns is that if you increase primary care spending, and this doesn't just mean paying primary care providers more money. I mean, I think that should be clear. I mean, this is, as Rachel noted, building primary care, which includes care management and other resources that are associated with population health. So I think the concern is, and I think this is a concern expressed by is that if they increase their primary care spending, but we don't see a reduction in overall spending, or it continues to increase at the rates that it has, that's going to be a concern. And I think that in itself will probably prove to be a demonstration of whether increasing primary care spending is successful in reducing overall healthcare, or at least the growth of overall healthcare costs in the future.
Does anyone else have any thoughts on that? I think that relates well to a question posed by Jill, which was, will increased investment in primary care result in higher healthcare costs? So did anyone else have any final thoughts on that topic?
If they do, that won't be good.
Yeah, it's interesting. I mean, the preliminary results we have in California at the provider organization level is that there's statistically significant associations between primary care spending and clinical outcomes, primary care spending and utilization, but not so much with total cost of care, at least at the provider organization level. There's an association, it's just not statistically significant. So it's interesting that that's the one area that there wasn't as much association or as strongly associated. But I think, we're just starting down this path of really trying to focus on this, and it's going to be important to monitor that as we go. It should become a bigger piece of the pie, but if the whole pie is continuing to get bigger, that's going to be problematic. So, yeah.
I think one other dimension to answering this question, it's not the specific of what is the right amount or what's the correct percent. But who's actually taking the actions necessary to address this question? We have, in many ways, oversimplified the debate of regulation versus market forces. And I think what the activities that we've discussed today represent is a melding of those two worlds. We have market forces that have been driving many of these new payment models. Many of these new payment models have been designed to encourage better performance of primary care and of primary care relative to the rest of the healthcare system. And those have been driven by market forces to a large degree. But at the same time, we have some of these states taking regulatory actions because they may not be satisfied that those market forces are being applied in a consistent or an equitable way. And then I'll just add the third dimension, you could say, I guess, is developing evidence and research. And that you really need sort of independent entities or trusted entities who can aggregate this data, pull it together, such as the NESCO group did and such as IHA has done. And so it isn't enough to say that one group should be the arbiter to determine what to do with these distributions of healthcare costs, but it's this melding of government regulation, market forces, and independent trusted research. And I hope that this panel discussion has provided some good examples of how those three things have worked together.
Great, thank you, Rachel. All right, we have just about 2 minutes left, so just going to ask in short statements to our panelists if you could or will redo or change your studies anytime in the future. If you could redo a study on primary care investment or give any tips to anybody, what would you change? Or what do you think was the most important thing that you learned?
I'll jump in and go first. I think, and this came up in another panel yesterday, someone said Medicaid is a puzzle. And given that some states have managed Medicaid and others are primarily fee-for-service, and the complexities of the services that potentially get included in Medicaid, and we did a lot of work here to try and straighten that out and get something consistent that was comparable over all the different states. But Medicaid would be one thing to tackle.
And I'd just like to give a shout out to NATO, who through some of its members is trying to tackle some of the basic questions of how the standardization process could be advanced, and to work with some of the other data standards groups. These are organizations that people like me are not as familiar with, but are absolutely essential to making the mechanics of these things work better. So I just like to give a shout out to NATO, not only for sponsoring this panel, but also for the work that they're doing to bring states together around some of the standardization discussions.
I would think two things. I mean, one is the timeliness of the data in the reports. I think we we have to be better at getting data collected and reported, and not be using 2 or 3-year-old data. No system, no organization of any size can live on 2-year-old data. I mean, it just doesn't make sense. And the other, I think, is the non-claims data. And just a remark, because I'm from Vermont and we have this all-payer model trying to be effective. I think the bottom line is going to be consumer satisfaction with the access of care and how much they're paying in their healthcare premiums. And I think that ultimately is the proof of the pudding. So.
All right, thank you. And I think we are at time. So I want to just thank our panelists and everyone who attended today. And I guess, Charles, I don't know if it's back to you or we just call it, but thank you, everybody.